Hi everyone, my name's Lil Downie and I just wanted to start by thanking Robert and Nick and the amazing team behind them for organising the conference and inviting me to be part of it. I've had a very lovely and productive time, so it's definitely worth flying across the world for. I'm going to talk to you today about the Baby Beyond Hearing project and a little bit about genomic newborn screening research in Australia. So Australia is a large island. I've come from Victoria in red there down south, and you probably usually associate Australia with the vast red desert and the interesting animals there. But Melbourne's probably a little bit more similar to Boston. And if you ever get the chance to visit, the things to see are the iconic laneway art, and we do have very good coffee there, which I'm missing. And I've come from the Royal Children's Hospital, which is a beautiful new facility, and it's co-located with the Murdoch Children's Research Institute, which is where the work I'm going to present has been done, and the future work will be done. So I'm going to share with you some of the outcomes from the Baby Beyond Hearing project, and as I talk about the outcomes, I'm just going to highlight some of the lessons that we learned along the way, because they have helped shape our next steps and our new genomic newborn sequencing research. So the work from Baby Beyond was funded by the Melbourne Genomics Health Alliance, and this is an organisation of hospitals and research facilities that were brought together to create evidence about how we should be using genomics in our healthcare system. And they use these disease cohort flagships to build that evidence. What we were aiming for was to identify who were the right patients, what was the right genomic test for them, and what was the right time to offer those people testing. And it's been a hugely successful program, and several of the flagships listed there have actually been translated into government-funded genomic testing for patients, including, hopefully at the end of this year, those in the congenital deafness flagship on which the Baby Beyond project was built. So what we did was actually took a population cohort of infants who were diagnosed with congenital hearing loss through our traditional newborn screening, and we offered them whole exome sequencing, which is what was available to us at the time. And we asked parents if they wanted just diagnostic testing for their baby's hearing loss, or whether they would like more predictive screening sort of genetic information from that test. So they could choose to have analysis of other genetic diseases that occurred in childhood. And we actually gave them the choice of having just treatable conditions, so maybe those that are more reflective of our traditional newborn screening aims, or they could have as much information as possible, so choice C on the right there, which included childhood-onset diseases that weren't treatable. And really what we were wanting to understand, as essentially this was an additional findings study, but we thought it would model some of the things we were interested in about how genomic newborn sequencing might look, particularly in an Australian context. And so what we were asking was, what choices should we be offering parents? And what disorders and genes did we want to test for? And we were very lucky at that time to be able to collaborate with some of the groups here and to share gene lists from both the BabySec project and the NC Nexus project. And we also wanted to know what variants to report. And it was a really important learning step for our laboratory, as we hadn't reported screening types of results from genomic data before without a phenotype. So it was a great learning experience for them, and we were able to generate new types of reports that reflected that this was sort of predictive testing. And what we found was really interesting. We had a third of our cohort who only wanted that diagnostic testing, and about 2/3 who were really interested in this additional genomic information. And many of them were happy to, or keen to have as much information as possible, so 41% of the cohort. And what was even more interesting was that 14% of all of the participants changed their mind about what kind of analysis they wanted at some point during the consent and results process. And they moved in all directions, so from wanting to opt in to additional findings after initially declining it, wanting to opt out of additional findings after accepting them, and moving between the two groups of additional findings. And I think that brings us to the first lesson that we learned, which is that people really wanted very different levels of information, and that their decision-making was fragile and dependent on what else was going on in their lives at that point in time. And that emphasised to us the importance of decision support, and that decision support is really interactive and flexible. And we were very lucky to be now moving from the little paper booklets that we printed and put into envelopes to a more interactive and flexible online decision aid tool that's been adapted from a Canadian group. So that's what we're using moving forward. And it also made us question how scalable offering parents those different choices would be in a future project. So this table just talks about some of the predictors of choices that people made, and we looked at this in terms of those who declined additional findings versus those who accepted them. And you can see here some really interesting points related to family size. So when it was a second baby rather than a first baby for the family, parents were nearly 5 times more likely to want that additional information. And if they identified it as Australian or New Zealander, they were nearly 4 times more likely to want that additional information. And we postulated that maybe that was due to having more trust in the Western medicine system or in our local healthcare service. And probably the most interesting and informative finding was that when we had babies that were recruited at a very young age, so less than 3 months, parents were significantly less likely to want that additional information. And so that brings us to lesson 2, which I think we've already heard about in the conference previously, is that significance of the newborn period, particularly when it's a first baby. And in Australia, we actually have active consent for our traditional newborn screening, so parents have to sign on the Guthrie card. And so we obviously want to avoid jeopardising that service in any way. And so that led us to discuss whether in future iterations of a genomic newborn sequencing project, we should be offering this consent and information either in pregnancy or maybe a little bit later down the track at the standard maternal child health nurse visits at 3 or 6 months. This flowchart just highlights the journey that the Baby Beyond participants went through, and really just to show you that we surveyed them at different times. So we had survey data from after they'd made their choice about how much analysis they wanted, after they received their diagnostic information for their child's hearing impairment, and then after they had additional findings results if they'd accepted that analysis. And this is a summary of some of the validated measures that we had in those surveys, and just highlights the impact of choice that people made. And again, I've presented the data here as those who declined additional findings and grouped those who accepted it. And you can see in that middle column that all the numbers are slightly lower. And that's demonstrating that people who wanted that additional information had slightly less anxiety around their decision. They had less decisional conflict, less intolerance of uncertainty. And in that bottom row, you can see the numbers are quite low. The denominator there is 100. And that was really reassuring that none of the groups had decisional regret. So that was very low across our study. Important to note there that it was a small cohort of infants and we were looking at rare conditions, so we didn't give back a very large number of additional findings results. We also did some work from those surveys. We had some open-ended questions where parents could just write about their experience, and Erin Tutty here, who's a genetic counsellor working with us, was able to do some qualitative analysis of those open-ended responses. And the themes that came out of that were that parents felt having this additional genetic information for their newborn gave them peace of mind, they felt empowered, and it enabled a focus on helping their child to reach their full potential. And most felt very comfortable with the results. Dania Veers, who we also work with, also interviewed a selection of people who participated in Baby Beyond. And I think that the words of the participants really highlight some of the themes that we have talked about. So I'm going to start with Prue, who declined any additional information. And she really talks about that fear of having her child be medicalised. So she says that cascade of intervention. They talk about that in maternal health intervention all the time, about how, like, once there's a problem, we have to do an annual scan for this, and every 6 months we're going to do a blood test for that sort of thing, where you're causing more issues than you're helping. Michelle, who chose treatable additional findings, really demonstrates well that idea of avoiding the diagnostic odyssey that we all value so much as physicians. My thinking was that if she was to get sick and start to have some kind of symptoms, the process for finding out what potentially was causing that sickness or those symptoms could be quite a long process of elimination. For example, trying to work out what's wrong with her. And if we had this genetic testing and we knew that she had these genetic predispositions, we could be onto it straight away. And finally, Quinn, who chose as much information as possible, really demonstrates the theme that came out, which was forewarned is forearmed. She said, well, my husband is the type of person who likes to know things, even if there's no treatment for things. It, I guess, reduces his anxiety knowing things. More information is better for him, I think. I think more information is better too. You know, then we can do research or support them the best way we can if they did have a certain condition. So lesson 3, reflecting on that data, I think, is that one size really doesn't fit all. And if we're looking at something that's acceptable at a population level and we want participation, which is essential for a population screening program, then we decided that our gene list really needs to reflect traditional newborn screening. So that's early onset and treatable conditions. And happily, this project also taught us, and a couple of other projects I'm going to mention in a minute, how to move away from the Excel spreadsheet gene list. And we now use Panel App Australia, which has been adapted from Panel App England, and that's an open source page, so you can just Google Panel App Australia. And our clinical service now uses this for all of our gene list curation. It's updated in a systematic way every 6 months, but also if an individual doctor is looking after a patient and discovers something about a gene and they want it to be on a gene list or they don't think it should be on a gene list, they can put that review in real time and it'll be considered by the service. So this is how we're going to put together our new gene list for our new project, which I'll talk about in a minute, and that will be open access. So we'd love to be collaborating with other groups on that. So the other lessons that have informed our new project, which I'll finish up with, that have occurred recently in Australia are Mackenzie's mission. So this was a federal government funded project where we were able to offer about 10,000 couples reproductive carrier screening, which included a funded round of IVF with pre-implantation genetic diagnosis if they were found to be high risk. And this was a great project in helping us realise what was important in our online decision support, and has helped us develop those to be very responsive to patients and what they want. And it was also great for our laboratory to practice and confirm that we can report screening results at scale in a reasonable timeframe. And the other program that's been really informative and very successful is run by Zanitza Stark, who I know many of you know, and Sebastian Lunke in our lab, and that's the acute care genomics program. So offering rapid whole genome sequencing to unwell babies in the NICU. And they have also been offered kind of like what we did in Baby Beyond, so an additional analysis list screening for paediatric conditions that might affect them later on. And these were both treatable and untreatable. So looking forward, we're very lucky in Australia that the government has come on board and they've announced 12 million Australian dollars to do further research in the genomic newborn sequencing space. And so our grant proposal is offering couples in pregnancy an online decision support tool. So we're going to get consent prior to an infant's birth. We're going to be testing 1,000 newborns using whole genome sequencing. And we are in a unique and lucky position of having all of the state's Guthrie cards in our laboratory. So that's what we're going to use for our sampling. We are going to analyse and report, I put on the slide 500 treatable onset disorders, but we're doing our gene list right now. And I can tell you even within our team, there's a lot of heated conversation about what is treatable. So we'll see where that gets to in terms of how many disorders are on that list. And we're hoping to store that data and reanalyse it. So, for example, if a child presents with developmental delay when they're 2, that data can be easily accessed and reanalysed in a broader way. And we're also lucky that within Australia there is, similar to here, that feeling of collaboration and that we all want to be working together on this. And so the genomic screening for Australian newborns, the GenScan Consortium, will bring together those groups that are utilising that new government funding. And what we hope to measure as outcomes of this is how feasible it is to scale up this kind of screening test. And we've also got a great health economist on board who's going to be providing really important input into the project and help with our outcomes. And we hope that using those lessons we've learned from the other projects will mean that we've struck the balance between providing benefits to families, not compromising in any way the uptake of our traditional newborn screening program. We hope it'll provide parents with informed consent and autonomy about what information they want for their child, and hopefully be distributed in an equitable way in our country. And we also hope it will link with our electronic medical records, and so be translatable and really reusable in healthcare when patients do have an evolving phenotype, and also able to be easily accessed for research in a federated way, both locally within the country and hopefully internationally. Many people to thank who've worked on both the Baby Beyond project and who are leading the next stages of our work in this area. Thanks very much.